today's training, we're going to have a quick simulation that'll highlight what we really want to learn today. It'll put that into a kind of real context, and then we'll go into the didactic portion. We need just a few, let's say 3 volunteers to assess this patient. We'll do it just like a regular call, okay? And then you'll respond in every way normal, and then we'll talk about the ways we could potentially do things better and the ways that we did things really well, okay? So who's our volunteers?
Okay.
Okay, all right, excellent. Okay. All right, so your dispatch call is for a 65-year-old female, recently had COVID, now less responsive, having respiratory difficulties. So that's the response call. Okay, and then we arrive. Okay, and your patient is over there. Okay.
You want me to take it?
Sure. Take the lead. Let me know what you need.
So I just look at the initial present appearance of the person as you walk in. There's family members there. We're looking at the environment around us, what kind of living situation they have going on.
Perfect. I love that you mentioned environment, because our first thing we're always assessing is the scene safety, right? So you had going down a stairway, thin stairway to a basement that is cluttered. Patient is on a bed in the basement. Patient is breathing spontaneously but has some labored breathing. Not responding verbally but is moving a bit. Family is pretty concerned because they last checked on her the night before and she seemed to be doing a little bit better. Actually seemed to be quite a bit better from COVID. And let's see here, you don't even see any signs of trauma. There's no dispersed medication containers, and the scene otherwise appears safe, assuming you got your respiratory equipment on. Yep. Mm-hmm.
So we'd have the proper PPE on, of course, before we came in, especially with the type of call, any call that we go on. Assume that there could be some type of contagious issue there. So then after that's all taken care of, I come in right up to the patient's bedside, looking for alertness, looking for their airway breathing, circulation, all those things, and then I would start treating depending if she's having acute.
So you move the clutter out of the way, because there's lots of clutter, remember? Okay. And then you notice that your patient is responding only to touch, kind of moans to that, doesn't talk to you, no verbal responses. And the skin's fairly dry, lips are a little bit dry, does have an occasional cough, and you do notice just a little bit extra noise from the breathing, sounding like a little bit of extra respiratory congestion, maybe some secretions in there. The skin is moderately perfused, so you got a little bit of a delayed capillary refill. It's not terrible, it's not great either. And then you do not notice any signs of trauma or anything like that.
So I get a base set of vitals, get a 4-lead put on, get end-tidal on them, blood pressure, pulse, and kind of start assessing from those results of the...
Excellent. So your vitals are as follows. Oxygen saturation on room air is 69. Heart rate is 120. Blood pressure is 85/52. And your end-tidal is a little on the low side.
So we put them on some oxygen.
Perfect. Okay.
Would we consider assisted respirations when she's that low?
Well, maybe I'll try throw a mask on them initially to see what happens. If it doesn't seem to be improving, then we'd look at some type of mechanical means of assisting her ventilations with a BVM.
Perfect. So you put on a non-rebreather mask at 15 liters, brings the saturations up to 91%.
Okay. Is the same patient become more alert at that point? Or are they still the same?
Still about the same. Yeah, so still kind of moan from time to time.
Are they answering any questions when I talk to them at all?
No, zero verbal response. Yeah.
All right. So, we'd start the process of either getting additional personnel here because of the how critical the patient is, and we'd start getting them moved over to our equipment and out to the ambulance. We don't wanna delay
Mhm.
any type of transport that way.
Yep. Mhm.
And we'd continue the assessment, maybe do a complete 12 lead,
Mhm.
depending on the situation, maybe a 15 lead if we see anything that
Mhm.
would indicate like an inferior wall type MI issues or ischemias.
Yep, so as you lay hands on the patient, you notice the skin's just a little bit cool, but not cold. You notice the 12 lead shows maybe just a little bit of ischemic changes, but you don't see any STEMI, okay? It is a little on the fast side, but it's narrow complex, looks like sinus tachycardia.
Does the chest seem to be rising and falling equally?
Yeah,
Is there
it's symmetric, there's no crepitation, no signs of chest trauma.
any-
good
lung sounds,
symmetric.
obviously, I'd be checking lung sounds. off the
That's
tape.
great, yes, and you would notice on lung sounds that they're kind of diffusely coarse throughout, and you hear some transmitted upper airway congestion or secretion.
If we were able to get some type of temperature to see if they have any type of fever
Mm-hmm.
going on, or if you can feel if
Temperature's
they're warm to
about-
the touch.
About 96.5 degrees.
Starting IV, we start giving some fluids due to the blood pressure was
Perfect.
85.
Mhm. Yep,
Systolic, so we wanna start giving them maybe a 250 bolus initially, and then start reassessing after that point to see if there's any improvement.
that's perfect. So you've had a couple of recyclings of the blood pressure. Before you even started your bolus, your pressure had dropped to 65 systolic. After that bolus of fluids, it increased to 78. So
Lung
it
sounds
initially
didn't
came down and then it's coming back up again a little bit with some fluids.
The lung sounds didn't change anything.
Still about the same, yeah, no more respiratory distress, but you do notice secretions do seem to be kind of increasing with time, okay?
And I didn't see any type of pitting edema in any of the
That's correct,
extremities.
no edema, and you're about 25 minutes away from the hospital.
Alright, well, we get another bolus of fluids. If the blood pressure isn't coming up, we'd start possibly looking at maybe some type of pressor to increase that
Perfect.
to a higher
So
level.
you've given a whole liter of fluids, you raise your blood pressure up to 89.
Okay.
And they do seem to be a little less responsive now than previously. So where there was kind of moans as you would do things, now you started a second IV and there is almost no response with that second IV. You're suctioning fairly frequently at this
So
point.
due to that situation, we'd be preparing for some type of airway,
Perfect.
either ideally, an intubation,
Mm-hmm.
ET tube. If not, we'd have a backup plan of the esophageal airways. And my partner and I would discuss that plan before we go
That's perfect.
about doing that. We have IV access, and we'd be probably going the route of using a ketamine.
Yeah, perfect.
Adult dosage for anesthesia, and then just see if they have a gag reflex or if they have any type of jaw locking, then we'd have to start looking down paralytic pathway as well.
And I would say, just to make things easier, just do the paralytic right up front. If
Okay.
you're gonna do a definitive airway, just go ahead and do that, okay?
Okay.
You're right, you can do it that way, but I think it just takes a little extra thought and it's one extra step potentially, as opposed to just kind of rapidly getting it done once you assess that it needs to be done, or once you come to that conclusion.
We try to pre-oxygenate as best we could, mechanically assisting doing that process.
Perfect.
Hopefully we'd have an additional person on scene at that point to help with administering the medication and getting the person positioned properly to achieve the airway that we wanted with the intubation.
Perfect. And so you get set up for your intubation, you go through your timeout, which sounds something like this. So we have our 65-year-old female needs to be intubated for airway protection. There's increased secretions and decreased responsiveness. We are going to use ketamine and we are going to use succinylcholine. We'll continue further sedation as needed with additional ketamine, which should help with which should be the best medication given our hypotension. We potentially expect additional hypotension following the procedure based on those medications. If I have difficulty with the intubation, we will do a supraglottic airway.
Good.
And
So-
then we've also assessed allergies too,
Right.
and there are no allergies to drugs.
So we'd be doing this en route to the hospital. If we need to, depending on the road situation, we may pull over just for the actual procedure, just to give us a better chance at success.
Perfect, okay. So, you do make an attempt for intubation and it goes well, with the exception of now your blood pressure is 52 systolic.
So we're gonna have to use some type of pressor, either if we choose to use dopamine or if we use epi, 2 to 10 mics for epi, or we could use the dopamine anywhere from 10 mics per kilo per minute to up to 20. We just titrate to effect.
Perfect, okay. And you do get improvements in blood pressure, you give additional fluid resuscitation. Blood pressure does come up, but it was severely low for probably 5 to 10 minutes before that actually started to come up. You arrive at the hospital and they give you high fives. Alright. Okay, so that's perfect. Care was excellent. How you guys handle this is really quite ideal. But there's one way we could do things just a little bit better, okay? And that'll bring us to our topic for today, okay? So,
Nice job, guys.
that was awesome. Really? So what happened well with that simulation? So they were organized. They went through almost an algorithmic approach on arrival, which is important. The reason that's important, I've said it a ton of times, but as we get ourselves into a situation where we're assessing people, it is challenging to take in all that information at once. So what does that mean? Your brain is getting in some ways overloaded, right? So starting in an algorithmic approach is important because it frees your mind up to help assess for irregularities, right? If you're too focused on what I'm going to do right when I get in there, you're going to miss other things. And scene safety is among the most important things, right? If you already know, okay, I'm going to go in there, I'm going to assess the scene, I'm going to ask a brief patient history, I'm going to assess various things, we'll get vital signs. You're going through the same thing on everybody. It's just going to help you to be more able to adjust to the irregularities that we see all the time, right? Because we don't just deal with cookie cutter patients, we have to be flexible. So I thought the way that they went through it was very good. They had the right idea in terms of they're a little hypotensive, let's try some fluids. But let's just not give 2 liters and see what happens. Let's give a little bit, reassess, and make sure we're right on the right track. That's perfect. That's exactly what we want to do. They didn't jump to any conclusions with the airway. We started where we should, right? Because no matter what, you want to try to get that oxygen back up. I think it is the right choice to just start with the non-rebreather. Assisted respirations, I think, are really good in the unresponsive patient. But we have to be a little bit careful with that because then you can put air into the tummy, cause vomiting and other things. So just have to be a little bit careful. But I think it's not wrong to do that. And it's situation by situation, but I think in this case what was explained, trying the non-rebreather, then converting to assisted respirations when the mental status changed, and then optimizing our pre-intubation parameters, okay? And we did a pretty good job of that, but one way we could do just a little bit better is to think about this up here, which is push dose epi, okay? So push dose epi is a tool that we can have available to us to be able to not only treat someone when they're hypotensive, but to also be able to kind of prepare for that, okay? And, unlike, if somebody arrests, where you're going through the algorithm, there's a little bit of flexibility in terms of how we use this medication. So the idea, though, in this scenario is you're about to do a procedure, meaning intubation, which in general, is gonna lower that person's blood pressure further. Doesn't matter that we're using ketamine, right? Because this person's catecholamine reserve is probably diminished, right? And ketamine, you get any of us a dose of ketamine, our heart rate's gonna go up, blood pressure will go up probably. But this person is kind of teetering on the edge, right? So what does that mean? That means their ability to accommodate that procedure is minimal. In addition, if you give them a medicine that should, in general, improve blood pressure, it may not, okay? And so basically the way I would word it is, it's not that ketamine is gonna necessarily help you, it's probably the best choice though, because it's the one that's gonna be least likely to further reduce the blood pressure. But we're gonna expect that that's gonna happen anyways, right? Because you get a little bit of peripheral vasodilation, a little bit of redistribution of fluids, which is kind of the opposite of what we want. And in addition, you're also relaxing them, okay? All those things are gonna, in addition to others, are gonna lead to a drop in blood pressure following intubation. So we are gonna expect that. So everything that was done in this simulation was excellent. This is icing on the cake, right? Because there are gonna be circumstances where we do the intubation and they may arrest afterwards. That is one of the most common times for somebody to arrest is after intubation, okay? And I would describe this patient almost like peri-arrest. So, like, you know, if your drain's down here, they're not like up here, you know, entering, you know, getting close to the drain. They're kind of like circling right there, right? They're not quite down the drain yet, but they're there, right? And you're just about to put them down the drain. And it's not your fault, right? You got to manage that airway. If you don't manage that airway en route, that person is probably going to die as well. But they'll die of respiratory failure or aspiration or some other problem. So it was absolutely the right thing to intubate, but we want to optimize our pre-intubation parameters. And I mean, in general, this wasn't even something that was done all that often pre-hospital, but now this is becoming more available. Push dose epi is awesome, okay? And our department has used this before, and in a way that I would say basically kept the person alive long enough to get to the hospital at least to be able to get a little bit extra chance to survive, okay? So I would encourage everyone to become comfortable with this, although it will take a little time, okay? So a few things to just sort of know about epinephrine before we move into what the protocol is. And there are a ton of different protocols. I've come across protocols that have multiple times the dose of what I'm recommending here, but this I would say is, this is the one I've come across the most. But anyway, so epinephrine, so it's a good drug, right? It can increase the contractility of the heart, it can increase heart rate, it can peripherally vasoconstrict, so you're shunting blood towards the core of the body to improve your hemodynamics. Now let's think about how the drug comes, right? So there's two concentrations that we see epinephrine in. You have the 1 to 1,000. What's that one for?
Allergic reaction.
Allergic reactions, right? Historically, it was used also for increasing doses of epi, but that's no longer done. Good evidence to say that, you know, if 1 milligram didn't work, 10 milligrams isn't going to work, right? So we're not doing that's historic. So now the only reason to use it is really allergic reaction. So 1 to 10,000 is what we use, we call code dose or cardiac epi, right? What does that actually mean? There is 1 gram in 10,000 mLs, which is 1 gram in 10 liters, right? So 1 to 1,000 is 1 gram in 1 liter, okay? So what we have in our code dose epi is a roughly 10 ml syringe, right? And that has 1 milligram in it, okay? So you have a 1 milligram, 10 ml syringe. If you get rid of 9 mLs of that stuff, so, and there's a number of ways to do this, but in general, how we're going to do that, we're going to waste 9 mLs, we're going to draw up 9 more mLs of normal saline. So what have you done to the concentration? You went from 1 milligram in 10 milliliters to what now? Yeah, exactly. You went to 0.1 milligrams, 100 micrograms per 10 mLs. Does that make sense? Okay, so the other thing I want us to think about epinephrine is how that's, let's just say they were started on a drip already. So a typical starting rate for a drip is 0.05 micrograms per kilogram per minute. Okay, so you're looking at an average person, let's just, for ease of math, we'll say they're 100 kilograms, right? So if it's 0.05 micrograms per kilogram per minute, you're looking at a typical starting dose on a drip of about 5 micrograms per minute. Does that make sense? Okay. So when we look at our protocol up here, which calls for anywhere from 5 to 20 micrograms per dose, which is 0.5 mLs to 2 mLs of that solution that we have made, that's a pretty low dose, right? And on the flip side of this, if you going for an interfacility transport and you see somebody who's on an epi drip and you're like, wow, that is a super high dose of epi, you're looking at kind of the high end. There is technically no maximum dose a physician can order for epi, but a pretty high dose would be 50 micrograms per minute. Okay? So just giving you that kind of range. It's about 5 micrograms to 50 micrograms per minute. Okay? So we're on the lower end of that spectrum, right? So if you do kind of the bigger dose, which is 20 micrograms, you're still a lot lower than it would be if it was an infusion at its max rate. Okay? But the thing you got to keep in mind is people's bodies adjust to drugs. This is the first time they're getting a pressor, right? So their response should be more robust than it would be if they've been on this drug for several hours and they're just not responding as well as they need to. Okay, and part of that is because these drugs rely on the body's reserve, and that's important to think about. If one of us has an IV in place and you push 5 micrograms of epinephrine, that response is way different than that person we pick up from the nursing facility who's kind of barely hanging in there. Does that make sense? Because their reserves are diminished, their adrenal response is going to be diminished, their vasomotor response may be diminished. There's lots of reasons why people just don't respond the same way. Otherwise, there wouldn't be a range, right? I would tell you to use a dose and it's going to work, but everyone's different, right? And when you have pre-hospital providers at our level here, we should be able to adjust to the circumstances so we have that range available. So again, how the simulation went was awesome, but would have been slightly better to say, okay, during our timeout, so we have Mr. Blank, we're going to intubate for airway protection and oxygenation. We're going to use succinylcholine for paralytic and ketamine for our sedation. Will you do further sedation with ketamine? But I also anticipate, right, because one of the things we talk about with airway during our timeout is anticipated complications or challenges, right? And I anticipate the blood pressure is going to get lower, so let's give a push dose of epi now. Okay? You have that push dose ready to go, right? Even if you're not going to give it, you have it ready to go. That's the other step, right? I'm not going to give it, but I have the push dose epi in my front pocket, ready to provide if we get lower. And I would say something like that if the pressure's say 95 to 100, right? We're not quite committed to wanting to increase that, but once you start getting in the 80s and you're gonna do an intubation, especially deep into the 80s or 70s, like was the situation here, it really is gonna help you to just give a little dose beforehand. And I would view this almost like pre-oxygenation, right? You are trying to optimize that patient's parameters for successful intubation. how do we define a successful intubation? Is that purely just getting an ET tube in place? No, right? Because would you have been better to just bag that patient but not make them severely hypotensive for 10 minutes, right? So it's the whole package, right? Successful intubation is, man, getting an effective airway in place, oxygenating, avoiding hypoxia, avoiding hypercarbia, avoiding hypotension. That's a successful intubation. I don't even necessarily say a successful procedure requires the actual intubation. If you abort the tube and put in a supraglottic device, but they didn't get hypoxic, they didn't get hypercarbic, they didn't get hypotensive, I would take that any day over the ET tube with hypoxia, hypotension, and all that other stuff. Does that make sense? So, and this is, nationally, this is more on the radar for quality control of intubations. Really, historically, it's like, well, did you get the tube? Okay, and then the second question would be like, how many attempts, right? But now it's not just that. It's like, okay, you got the ET tube, that's awesome. First pass success, that's great. But how are our hemodynamic parameters? How is the oxygenation during that procedure? Okay. So we're already awesome, right? But we're trying to take our awesomeness to the next level, so we're going to try to really pay attention to those parameters. Push Dose Epi is another tool we have available to help us be able to do that, optimize those parameters. And this is just one of multiple examples where Push Dose Epi can be helpful for us. It doesn't have to be pre-intubation. You might just have the person who's severely hypotensive, they're maybe already intubated, or any number of reasons this is reasonable, okay? Because there are options. I've started dirty epi drips and things like this, but that's different scenarios. This is just easy, and it does have a pretty decent effect. Now, important to think about, this is kind of extra credit, but does anyone know what the half-life of epinephrine intravenously is?
5 minutes.
What's that?
5 minutes.
You're really close. That's a really good guess. And honestly, that might even be right in some people, but it's about 2 to 3 minutes. Okay, and so you consider that. What does that mean? So your effectiveness of that drug is going to be about half within about 2 to 3 minutes, or the bioavailability. So you're going to have some effect usually for 5 to 10 minutes. Okay. So you have to expect that you give that push dose of epi, 5 to 10 minutes later you need to be reassessing. But we're doing that anyways, right? Because typically our cuff is going to be going off every 5 minutes or so. We're going to be seeing that. So yeah, that's a really good guess. But yeah, about 2 to 3-ish minutes. it lasts a little bit longer, just because it causes vasoconstriction, uptake's a little bit lower, things like that. But for IV push dose epi, you're going to get about, in general, 5 to 10 minutes of effect. Okay, and it's but that's perfect for us, right? Because we have relatively short transports, right? And taking the time to make a drip just doesn't usually make sense, right? And if we're doing an interfacility transport and the person's blood pressure is already soft before we leave, we're going to be thinking into the future, like, gosh, this is a potential pitfall for us. Let's have a presser in drip form available, ready to go. Right? All right. Are there any questions about this at all? And this is, so there are, like I said, other protocols for this, and this one I just came up with not that long ago, so there may be some ways to make it better. But that said, look it over, try to get comfortable with it. If you have feedback for me on it, questions, anything like that, just let me know. Okay. Are there any questions about push dose epi?